All right, we're diving into one of the most high-stakes topics in all of medicine, emergency airway management. This is all about those first critical moments where every single decision you make could change everything. Let's get right into it.
This right here, this is the golden rule. It's the first thing that should pop into your head. Forget trying to figure out the exact diagnosis for a second, because look, if the patient can't get oxygen into their body, nothing else we do is going to matter. It's always airway and oxygen first, always.
And this is the why behind it all. The stakes are just incredibly high. You're in a race against the clock, and you've only got a few minutes before permanent brain damage starts to set in. Every second you hesitate is another second the brain is being starved. That's the brutal reality of what we're dealing with.
So, where do we start? Well, it all begins with 3 simple things you can do from the end of the bed before you even lay a hand on the patient. It's about using your eyes, your ears, and your brain to get an instant snapshot of the situation. You can learn so much just by watching. I mean, can they talk to you in full sentences? If they're gasping out single words, that's a huge red flag for respiratory distress. And don't mistake agitation or confusion for just a behavioral issue. A lot of times that's an early sign of hypoxia. And drowsiness, that's a really bad sign. It means they're getting tired, they're exhausting all their energy just to breathe, and they're about to give up. Okay, so after you look, you listen. And these sounds, they're clues telling you exactly what's wrong. If you hear gurgling, it means they're trying to breathe through liquid, saliva, vomit, whatever. You need to get the section in there right away. Snoring? In an unconscious patient, that's not peaceful sleep. That's their tongue falling back and blocking everything. A simple jaw thrust can fix that. But stridor, that high-pitched, desperate sound, that's a severe blockage up top. That's a true I need help in this room right now emergency. And that's the principle you have to burn into your brain. A clear, open, safe airway should be silent. Any noise you hear means there's an obstruction. It's that simple. Your job is to hear the sound, figure out what it means, and fix it. Fast. Now let's talk about a magic number in airway management, and that number is 8. This refers to the Glasgow Coma Scale, or GCS. It's how we measure someone's level of consciousness. A fully awake person is a 15. The old saying goes, GCS less than 8, intubate. Why? Because at that point, the patient has lost their protective reflexes, like coughing or swallowing. They literally can't protect their own airway anymore. So, we figured out there's a problem. The next move is oxygen. But it's not a one-size-fits-all kind of deal. You have to think of it like an escalation ladder. You're trying to match the right tool to how sick the patient is. So here's how that ladder works. We start at the bottom rung with nasal prongs for someone who's just a little hypoxic. If that's not cutting it, we climb up to a simple face mask. Still not good enough? We go for the non-rebreather mask, which can deliver a ton of oxygen. And then, at the very top, for people in real trouble, we have things like high flow or non-invasive ventilation. Think CPAP or BiPAP. These machines don't just give oxygen. They actively help push air into the lungs to take some of the workload off the patient. But, and this is a really important but, there's a shortcut. If your patient is severely hypoxic, if their oxygen levels are circling the drain, you do not have time to climb the ladder one step at a time. You jump straight to the top. Slap on a non-rebreather mask and crank that oxygen flow all the way up to 15 liters. Flood them with oxygen first, ask questions later. So, what happens when giving oxygen isn't enough because the road itself is blocked? That's when we need to reach for our tools, airway adjuncts, to physically pry that passage open so air can get through. Our 2 most basic tools are the OPA and the NPA, and knowing which one to grab is absolutely critical. An OPA goes in the mouth. It's only for a patient who is completely out, no gag reflex at all. If you try to put this in someone who's even a little bit awake, they're going to gag and vomit. For that patient, the one who's semi-conscious, you use an NPA, which slides into the nose. It does the same job, but is tolerated much, much better. Okay, but what if the basic stuff isn't working, and you're not ready to intubate? That's where the LMA, or laryngeal mask airway, comes in. This thing is a fantastic rescue device. You can slide it in without seeing what you're doing, and it can help you ventilate someone in a pinch. But, and this is key, it's a bridge, not a destination. It sits above the vocal cords, so it doesn't fully protect the lungs from anything coming up from the stomach. This right here, this is probably the hardest, but most important skill you can develop. It's that gut feeling, that intuition that tells you your patient is about to fall off a cliff. It's recognizing that despite everything you're doing, they're tiring out, and a total collapse is just moments away. So what are you looking for? What are those telltale signs that scream at you that it's time to stop messing around and prepare for the definitive airway, putting a breathing tube right into their windpipe? Here they are. If the patient's getting sleepier, that's not a good thing. It means they're losing their fight. If they can no longer speak, if they look exhausted, if their oxygen levels are dropping even though you've got them on high-flow oxygen, your therapy is failing. And if you see paradoxical breathing, where their chest goes in when their belly goes out, that's the diaphragm waving a white flag. They're about to stop breathing. There is zero ambiguity here. When you see these signs, the time for waiting to see is over. You don't wait for the patient to stop breathing entirely. You act. You get everything ready for a controlled, proactive intubation. Right now. You know, all of these skills and tools are crucial, but what really ties them together is the expert mindset. This isn't just about running down a checklist. It's about constantly thinking 3 steps ahead, anticipating the next problem, and always asking, what's the worst that could happen, and what's my plan for it?
And here's the difference. A junior person might look at a struggling patient and think, okay, well, they're breathing. An ICU clinician looks at that same patient and thinks, yeah, they're breathing now, but for how much longer? They see the trend. Is the airway truly safe? Are they tiring out? They're playing chess, not checkers, trying to prevent the crash they see coming in the next 15 minutes.
So this is the entire playbook, the whole mental model in one place. You look, listen, and assess. You start oxygen. You add an adjunct if you need it. You escalate to more advanced support like high flow or even a bag valve mask. And through every single one of those steps, you are constantly reassessing, always asking yourself if you need to jump to the next level, all the way up to intubation.
And if you remember nothing else, remember this philosophy. The whole game is about being proactive, not reactive. Give oxygen early, support the airway early, escalate your treatment early, never let yourself get behind the 8 ball, because every single thing we've talked about serves one fundamental, undeniable truth: oxygen is life.